Dr. S. Shankar is the Associate Professor of Internal Medicine, Rheumatology and Clinical Immunology at AFMC Pune. He is a gold medalist from Pune University, where he did his MBBS and MD. He has trained in rheumatology and clinical immunology from AIIMS, New Delhi. And he is a recipient of many academic research awards, including Young Scientist Award in 2006. He is currently also the Editor-in-Chief of Indian Journal of Rheumatology, and is a referee and review of many journals. He is a keen researcher with multiple publications, including 12 in international journals. He will talk on management of vasculitis with a few useful tips for clinical practice.
Thank you, ma'am. Vasculitis, as you know, it's not one single disease. It encompasses a whole range of diseases. So when Dr. Chandrasekhara told me that I would like to talk about management of vasculitis, I was wondering how best to approach the situation. The easy way would have been possibly to name each vasculitis and tell the treatment, but there would also been quite a bad way, because I'm sure nothing would have transpired between us. So most of the time I've taken in planning this is how to say it, and hopefully I finally chose this outline. I shall give you a very brief overview of vasculitis in maybe just a handful of slides. Then she'll discuss the management principles as to when to suspect vasculitis, which I think is the most important question. And then we should be aware of the diseases which mimic vasculitis. Then once you have identified the vasculitis, we should be very clear whether this vasculitis is active or it is just the old damage that you are seeing. And finally, you should be able to decide on how you are going to treat. So vasculitis, as you are aware, is inflammation of blood vessels. Now blood vessels are, the aorta is also a blood vessel, and so are small capillaries. Blood vessels are there in every part of your body, right from your brain to your foot. So exactly like that, vasculitis also lands up affecting any part of your body. That's why they are so protean. The affection can be either localized or generalized, and when it is focal, it can, if just the wall gets damaged, there can be aneurysm or it can get ruptured. A segment can get damaged, and depending upon the various ways it gets damaged, you will end up having different symptomatology. Primary vasculitis is that group where you don't know the reason, or idiopathic. Long list of diseases in that. Idiopathic, I'm sure many of you know, but like my old professor used to say, it means it's a place where we don't know anything, the doctor is an idiot and the patient's condition is pathetic. That becomes idiopathic. Secondary vasculitis syndromes, on the other hand, is a group where we do know some causes. These are classically, interestingly, most of the secondary vasculitis only land up affecting the small vessels, and invariably they would come as purpura in the lower limbs or upper limbs. So your infections like hepatitis B, hepatitis C, infective endocarditis, various connective tissue disorders including lupus, your paraproteinemias, whenever you take any drug, for example any antibiotic or even otherwise, and many a times occult malignancy. In fact, if you actually go through various NEJM, the Massachusetts General Hospital case records and all, this is a very popular kind of a stuff. Even in the CPCs and everything, you will invariably find that the doctor did not do a PR, and actually there was an occult, say, rectal carcinoma or something like that, and the presentation was vasculitis. So, but the clue here is that invariably a good clinician with a good history, good investigation and a thorough examination is likely to get some clue. I think that I'll stop. That's all the overview I'm going to give. The most important thing is, when do we suspect vasculitis? Now in this, I will say there are, I deliberately divided into 3 different scenarios. Scenario 1 is when, let's say, India has to play one day international with Holland, and if you're going to, I'm sure all of you will bet definitely will win. So there are 3 clinical, but you know what, if you play 100 games, we can lose 1 or 2 also on a bad day, or if Holland has got an excellent day. So these 3 scenarios, you can put your bet as much as what you would put in India versus Holland. One is if you ever come across a person with palpable purpura. Whenever you see these kind of purpuric rashes, the first thought which comes is, does this person have thrombocytopenia? You do a platelet count, it comes as 4 lakh, 5 lakh, that's out, then you are left with vasculitis, hypersensitivity vasculitis. Classically affects the lower limbs as in henoch-Schwann purpura. In adults, it can affect other places also, though generally it prefers the lower limbs. The second clinical scenario is if and when a person comes with mononeuritis or mononeuritis multiplex. Now, worldwide, the commonest cause is diabetes mellitus. In India, I will put one more cause, leprosy at number 1 position, and HIV. All these three are so easy to exclude. All you have to do is one sugar, fasting PP, HbA1c, diabetes is out. HIV ELISA, HIV is out. A detailed examination for thickened nerves, anesthetic patch or something, reasonably sure that leprosy is also out. You are left only with vasculitis. You can put your bet on it. The third clinical scenario is a renopulmonary syndrome. If you are just going to have lung opacities alone, hundreds of differential diagnoses. If you are going to have only some form of a glomerulonephritis, again lots of differential diagnoses. Combine the two, you can again, there are hardly 4-5 conditions which come to mind. Lupus of course is one of them, but SLE you would have got a clue even otherwise, and your ANA and other things will tell you. One more condition which is not vasculitis is Goodpasture syndrome, but besides that it is either vaginous granulomatosis or microscopic polyangiitis or Schultz-Strauss syndrome. So in other words, the moment you have a combination of a glomerulonephritis in the kidney and some form of breathlessness and lung infiltrations in the lung. So these three situations, a palpable purpura, a mononeuritis and a renopulmonary syndrome, are as good as one match of India versus Holland. But then I get you another match, India versus Bangladesh. Now the way we are very happy with the way we played against New Zealand, but sometimes we are not so good. I am sure you are not going to put 90s to 10, you will say 70-30. I mean, we are likely to defeat Bangladesh again and again, but you are not going to put as much money as you put against Holland. Now those are the other group of this thing. First is non-healing ulcers. So if see, there are so many causes of non-healing ulcers, starting from your deepened thrombosis or a person who has got a varicose veins to other conditions. But remember, one important duty does remain a vasculitic syndrome, especially if the ulcer is going on for more than a few months. Definitely keep this as. The second one is if at all there is a gangrene which develops. Now interestingly, gangrene means arterial. The moment artery, just about 4-5 conditions should come to the mind. Besides the list of medium vessel vasculitis, the only other few conditions are say antiphospholipid antibody syndrome, hyperhomocystinemia, or if it is predominantly lower limb, atherosclerosis, in a smoker, upper limb or lower limb, Burgess disease. So the number of conditions which can land up causing a digital gangrene is limited, and you would invariably land up having, so that's why it's not India versus Holland but India versus Bangladesh. The third condition would be if a person does come with, let's say, something like pulmonary nodules, you are very happy it is likely to be TB, you keep giving ATT, but after 3 months you find fever is persisting, one new nodule has also come up and everything, and then if you are very lucky you may actually find that the nose is deformed, but you may not be so lucky. But the moment a non-resolving TB and doesn't look like a malignancy, do start thinking of something like Wegener's or this thing in the mind. There are few other conditions. If a person has got refractory asthma and you find that eosinophil count is 40%, 50%, asthma per se doesn't cause. Of course, the other DDs like allergic bronchopulmonary aspergillosis and all, but Schurz-Strauss should also come in mind. If you are very lucky, you may find a few active urinary sediments, you may find a few purpura, then it is definitely Schurz-Strauss. But even if it is not there, some condition should come to mind. If you find a young patient hypertensive, you actually are sincere enough doctor to look at all peripheral pulses, which most of us do not do, and you actually find that there is some asymmetry and the blood pressure here, systolic blood pressure is 20 millimeter higher the other side, put your bet on Takayasu. So these are some other conditions where the word vasculitis comes, you should suspect. I have covered these two important scenarios on the left side. On the right side is 50-50. It's a India versus Pakistan match. It could be anything. But remember, if there's a multi-system disease, you are having 3 unconnected systems somehow. You all been taught, think of connective tissue disorders. Do think of vasculitis also. Unexplained constitutional signs. The person has been generally feeling weak, has lost 8 kgs weight loss, has been having persistent fever, PU for a long time, vasculitis. Myalgia, arthralgias, arthritis, you are not very, it's not a typical SLE, it is not typical rheumatoid, everything, some vasculitis. Keeps having either an emergency, acute abdomen with distension, and a surgeon says that the entire area is gangrenous, or recurrent abdominal anginas, just keep. So all these weird things also, these are the when to suspect vasculitis. Okay, now you have actually suspected vasculitis. The next step is, are there other diseases which can confuse you? So I think we should be very clear about vasculitis mimics also, or they are also sometimes known as pseudovasculitis. Now I told you palpable purpura is a almost sure shot of vasculitis, but you have other conditions like viral hemorrhagic fevers, rickettsia, etc., where very similar thing can come. The story may not be the same, but obviously you know one is just for a few days, and other clues will be there. But if you see like this, these are the other conditions which come to mind. A person who has got a digital gangrene, we already discussed it. Burgess disease, one should not forget, and the commonest interestingly would possibly atherosclerosis, and especially in the era of diabetes, that may be even commoner, especially in the lower limb. Disseminated intravascular coagulation can come in this form. What you are seeing in the nose is purpura fulminans. You can have extensive gangrene. Every gangrene obviously is not vasculitis. I am deliberately showing you other causes which can mimic it. A person who comes, let's say, with an MI or angina, your cardiologist takes him, he does a procedure, angiography, 6 hours later he develops this kind of a scenario, and then this is obviously not vasculitis, this is related to what is called as cholesterol emboli. Then a classic thrombocytopenia can land up coming with purpura. Of course, you must do a platelet count and check up that it is a garden variety thrombocytopenia. Patients who have got endocarditis or atrial myxomas can through emboli, can come with small purpuric lesions or even these kind of infarcts. Other microangiopathic hemolytic anemias like can occur in thrombotic thrombocytopenic purpura or antiphospholipid antibody syndrome also, they can also come like this. So the point is, there are a whole group of diseases which can mimic vasculitis. So these are, I think, before we discuss on treatment of vasculitis, you see you would actually kill the patient if you even dreamt of giving steroids or cyclophosphamide in a person who was possibly having an infection, and then even God possibly may not be able to save him. So you must suspect vasculitis correctly, and number 2 is be sure that it is not something else which is obvious. Now that we are smart enough to have done the first 2 things, then we say what is the type of vasculitis. Now this is an area which is plagued with confusion, because there are at least 5 types of classification which I can tell you, maybe there are more. Vasculitis is classified on the basis of clinical syndromes, on vessel size, on the basis of lab markers, on the type of pathology, and on the type of etiology. So depending upon who is writing the article, you may land up seeing different types of therapies being discussed. So first let us understand the classification a little bit. On the basis of syndrome, it is 3 broad groups. Either it is systemic necrotizing vasculitis, which is possibly like your classical polyarteritis nodosa, and your things like Wegener's, microscopic polyarteritis, and Churg-Strauss syndrome. The second one is cutaneous vasculitis syndrome, example Hinoch-Schönlein purpura which we see in children, and the hypersensitivity vasculitis. And the third group is the large vessel vasculitis, in which there are 2 important one is the giant cell arteritis and the Takayasu's arteritis. So what occurs, the ones which are marked in yellow are the ones which are the systemic necrotizing vasculitis, the others I have just marked here. Then there came a classification called Chapel-Hill classification, who said that okay, now let's not look at the syndromic approach, we will see whether it is a small vessel, medium vessel, or a large vessel. Small vessel are, that is, venules, arterioles, and capillaries. you have a whole range of diseases and if you remember the first slide which I told, secondary vasculitis, most of them would come in the small vessel. In the medium vessel, the two classical polyarteritis and Kawasaki are the pure medium vessel ones, while the other ones like Wegener's, microscopic, Schurk-Strock vasculitis and all, they affect both medium and small. In the large, you have only two of them. Just this diagram tells you, see, one thing is, if most of the vasculitis is not pure to one group. If it goes to medium and small, it get classified as small. If it goes to large and medium, it will get classified as medium. So the classification wise, it always goes towards the smallest vessel it affects. So to understand, so if you realize, it's very interesting, things like if you see Goodpasture, your cutaneous vasculitis, Hinox-Schondlin, all of them, they are hanging around in the small vessel vasculitis. The medium vessel vasculitis is only two important ones, Pan and Kawasaki, and the large are these two. We just finished two types of classification. Then all this classification was done before about 10-15 years ago. ANCA came into scene, that is the anti-neutrophilic cytoplasmic antibody, and suddenly they found that some of these vasculitis are indeed associated with ANCA. So a lot of studies will come say that this drug is very good in ANCA associated vasculitis. And what is an ANCA associated vasculitis? These are the three important one, Wegener's, microscopic Pan and Schurk-Strock. All of them, if you realize, are the systemic necrotizing vasculitis, which get classified as ANCA associated vasculitis. The fourth way of looking at it is from the pathologist point of view. See, they also have to have that pound of flesh. So they say that, listen, all vasculitis is either systemic necrotizing vasculitis or granulomatous, like your giant cell arteritis or Wegener granulomatous in the lung, or it is leukocytoclastic vasculitis, the way we see hypersensitivity. See, the same four things, but we are trying to look at it from different. It's like that classical one elephant and six blind men trying to describe it from six different ways. Last but not the least, the class etiology wise, it is primary or secondary, which we already told. Why I am telling you all this is, sometimes when you read, you may land up reading a particular article and he might say, this drug is effective in ANCA-associated vasculitis, this is effective in secondary vasculitis, this is effective in granulomatous. It all depends upon who is the one who is looking at it. So the important thing to remember is, don't remember any of these things. We will go through a very simple stuff. Now ACR, if you go through American College of Rheumatology, they love to make huge criteria. Rheumatoid has got 7 criteria, SLE has got 11. Each of these vasculitis, important diseases, have got anything from 7 to 11 criteria, which I shall not at all confuse you with. What is important is, most of these criteria have got a sensitivity and specificity of 80 to 95%, nothing to feel excited about, because please understand, the positive predictive value is only 20 to 40%. Now what is the key difference between these two? See, if the person definitely has a proven disease, then the test is also positive, that is called the sensitivity. But if I tell you the other way around, listen, if I am suspecting vasculitis, what is the chance this guy has the disease? Then it is only 20 to 40%. That is why all these criteria are little weak. So at the end of the day, it is the clinical judgment which makes the most important thing. So on a practical angle, we already told when to suspect vasculitis. We know those 7-8 conditions when the tubulite should burn. This might be vasculitis. You rule out all the infections and everything. The practical angle is only 3. One, you would like to be very sure which are the organs which are involved, because at the end of the day, your treatment is going to be based on the organ. You can call it Schurk-Strock or you can call it Wegener's. If the kidney has got glomerular nephritis, you are going to become aggressive. That is the secret. So you define the organ. Is it only skin? Is it skin and joints? It is lung and kidney? It is brain and lung? Please define that. Second, with the way the pattern is going, is it likely to be small vessel, medium vessel or large vessel? If the whole problem is only asymmetry of pulses, then it is large vessel. If there are small purpuric lesions and glomerular nephritis, it is a small vessel. If there is a digital gangrene, it is a medium vessel. Once you have seen these two, you say which is the likely syndrome. By combination of these three things, you should be able to hit upon the diagnosis most of the time. The first set of investigations which you would do is to define the organ. So obviously, starting from your HbTLC, DLC, you would like to do a liver function test, renal function test, chest X-ray, and all the tests which I shall not mention at all. This should have anyway done as a good physician. I shall only focus on these 4 specific investigations: ANCA, arteriography, tissue biopsy, EMG and nerve conduction study. Now ANCA is, you have this is anti-neutrophilic cytoplasmic antibodies which is looked at through indirect immunofluorescence and by ELISA. You will end up getting three patterns: perinuclear, cytoplasmic and atypical, and this is later substantiated by an ELISA test. This is how a C ANCA looks like. The important point to remember is this is seen with an antigen called proteinase 3 and seen in a large percentage of people with vaginous granulomatosis, some amount of microscopic polyarthritis also. The P ANCA is associated with an antigen called myeloperoxidase, and the atypical ANCA is associated with multiple other antigens. You see, ANCA can be seen in many other conditions besides your vasculitis, but ANCA it's possibly it's not such a hot thing also, because there was a very nice study way back in 99 it came out. They looked at some almost 80 patients who were C ANCA positive and found that even among the people who are proteinase 3 positive, only 13 finally turned out to be vaginous granulomatosis. So there is lot of false positivity and all. So in a given clinical scenario, ANCA is useful, must be confirmed by ELISA. I think that should be the only message which should go through. Arteriography is extremely useful, especially in the medium and the large vessel. Small vessel obviously will show nothing because of venules and capillaries. So for example, this is a digital subtraction angiography in a patient. You can you appreciate these small aneurysms which are there in a patient with polyarthritis nodosa. Here again you can see multiple aneurysms which can be seen. Even peripheral aneurysms can be seen in this patient. In a PAN, remember, the importance is only given to the mesenteric and the renal aneurysms, and not much importance, even the classification is given to the lower limb aneurysms. The gold standard is at the end of the day the histopath only. So what occurs is that you would like to go and take out a reasonable tissue which you can. Say for example in vaginals, if you're lucky you take from the upper airway, you may find predominant granulomas. In the lung you may find both granuloma and vasculitis. Well, if you do a kidney biopsy, you would find predominant vasculitis only. So in a case of PAN, you may like this is a case which shows glomerulitis. Here it's from the intestine which got infarcted. You can actually see that there is some necrosis here. This is from a post-mortem heart, you can make out. In a patient of vaginals, in the lung, if you are able to get a biopsy, you will find granulomas. In the sinus, you are able to see granulomas. If in a giant cell arteritis, if you do a biopsy, you would find the evidence of that there is a entire this thing is destroyed, elastin, and there are granulomas. So the really speaking, where you take the biopsy from would greatly depend upon which is the type of vasculitis you are suspecting. So now with the combination of three things, which is the organ, which you have defined the organ well, you have got a clue of whether it is a medium, small or a large vessel this thing, and with the help of investigation you are more or less told this is likely to be this type of this thing. Then you would like to distinguish between two things, activity and damage. Like Dr. biopsy, you will find granulomas. In the sinus you are able to see granulomas. If in a giant cell arteritis, if you do a biopsy, you would find the evidence of that there is a entire this thing is destroyed, elastin, and there are granulomas. So the really speaking, where you take the biopsy from would greatly depend upon which is the type of vasculitis you are suspecting. So now with the combination of three things, which is the organ, which you have defined the organ well, you have got a clue of whether it is a medium, small or a large vessel this thing, and with the help of investigation you are more or less told this is likely to be this type of this thing. Then you would like to distinguish between two things, activity and damage. Like Dr. Dharmanand showed, one way of remembering all rheumatology diseases is a building is on fire. When a building is on fire, you have got an obligation to put out the fire. If you land up reaching the building within the first half an hour, you can actually save everything. If you land up reaching after one day, what would occur is that most of the windows and the doors would have got burnt out. So, but what occurs is the patient from a practical point of view would land up continuing having pain, both A because of the fire itself and B because of the damaged windows and doors. So what occurs is it becomes slightly difficult for us to understand whether the problem is because of the fire or is it because of the damage. Say in terms of a kidney, if you look at it, the person initially may have very active urinary sediment with proteinuria and everything. You may treat him aggressively, but after 3 months you find that protein is still 600 milligram, it's continuing to come out, and the creatinine is at 2.4. You would like to be sure whether is it an active disease now, should I continue this, or is it going to be a long term damage which is remaining. So therefore you would like to see, there are various ways people have tried to look at the disease activity and the disease damage. Now, the difficulty is, unlike rheumatoid arthritis where some simple tests and x-rays would do, vasculitis is very confusing and vague with so much of involvement. Needless to say, you land up having a complicated scoring system and try to give weightage to each of the score. Don't bother to remember this. Suffice to say that you have different types of scoring system. For example, activity, you have got BVAS, Birmingham's Vasculitis Activity Score, you have a damage index, 5-factor score, you have, so different types of score you try to do. They are just trying to show one score, another score, damage index, but suffice to say, you would like to try to see whether this person is going active disease or is just a residual damage which is left over. Now that you have been able to do these two things, finally we come down to what is it that we are going to exactly treat. Before I come to the details, I will tell you something very simple. At the end of the day, there are 3 types of vasculitis. Small vessel, the treatment is nothing. Most often you have to give no treatment at all, especially if it is only the skin. If there is a little bit of involvement of the joints, some NSAIDs, if the other organs involved, treat it slightly more aggressively. Medium vessel I will leave alone. The large vessel are beautifully steroid responsive. So something like giant cell arteritis, only steroids. Kawasaki disease, steroid with little bit of methotrexate. The details I will come to. So the entire drama of management really comes down to the center group of either the ANCA associated vasculitis or the ones which you call the Wegener's and all the things, PAN, etc., which I shall discuss in little bit detail. So whenever you look at a person, I put these deliberately together. In a child you look at the hinox-schonlein purpura, and adults you look at the hypersensitivity vasculitis, which can be because of a drug or a connective tissue disorder or an underlying malignancy. Classically, in adult you may only have rash, in a child you may likely to have a permutation combination of all of these 4. The treatment majority is supportive. If you have an obvious offending agent, please remove it. If you have been given some drug which has caused it, stop the drug. If there is a lot of pain in the joints, NSAIDs. This will suffice for most of the patients. You may need to give steroids if the skin lesions are persisting for a long time, or if there is some degree of renal involvement. But it's most of the time in skin and renal you don't have to give it at all. You just have to give it's a persistent, it's useful in arthralgias and abdominal discomfort. If the patient does go into RPG and kind of thing, then you may have to give plasma exchange and even cytotoxic drug. But do remember, hypersensitive vasculitis treatment is supportive, that's all. I will deliberately shift to the large vessel because again that's easy to understand. In Takayasu disease, in the pre-pulseless stage, it is actually inflammation. It is very difficult to diagnose at that point, whereas by the time you are finding an asymmetry of the pulses, possibly the damage has already set in. Now what occurs is that in the at this point of time, it's difficult to decide how to go about treating. You do an angiography, you find and you confirm your diagnosis, then depending upon the type of involvement you classify it, and instead of a conventional angiography, nowadays MR angiography has been found to be equally good if not better. But finally you have to decide, what am I going to treat? Am I going to give medical therapy or surgical therapy? And again, your CRP ESR may not be very useful because you see, after all it's just a blood vessel which is inflamed, and it will be very difficult to say. So even assessment of the inflammation is extremely difficult. So there are a lot of conflicting results, but yes, one can give steroids and then taper it off. Methotrexate may have a role in steroid resistant cases. There have been studies with leflunomide, but what is really important is your renal artery stenosis, etc., which can develop. You can do a stenting and get down the wherever the stenting has got a huge role. Some studies from India which say that it's a very common cause of renovascular hypertension, with this being the most common mode of presentation. And what occurs is that this is also the most common cause of mortality. So there is a huge role for surgical stenting. Giant cell arteritis luckily responds beautifully with steroids. So you don't even have to give any other DMR, just steroids would be good enough. Now we come to the difficult vasculitis. Most of them follow the same principle, whether it's only the duration which varies. So you induce remission, something like malignancy, you maintain it and you prevent the relapse. Once you have decided, the best drug till today has been cyclophosphamide oral, 2 milligram per kg per day, and along with steroids. How long do you give? Now this is very interesting. The duration is, now what occurred is that people tried cyclophosphamide, they gave it for a long time, found excellent result, but also a lot of side effects. Then they realized that after 6 months or so, you can change over to something else. So in came azathioprine, methotrexate and mycophenolate mofetil, and they found that they were actually doing quite well. Then someone said, if you give 2 milligram per kg per day, let's say 100 milligram every day, which means at the end of 1 month you are given 3 grams. So in the month of 6 months you are given 18 grams, lot of side effect. Why not give pulse therapy? They gave pulse therapy, found efficacy was equally good, but follow up for another some time, relapses are much higher. So do remember, the gold standard still remains oral cyclophosphamide. In lupus nephritis, mycophenolate mofetil has come excellently in inducing remission, but not so in vasculitis. If when you see the patient there is a life or an organ threatening disease, there is a role for giving methylpred pulses also. So how long do you give? A disease like polyarteritis nodosa is monophasic, and possibly you may have to give the total duration only for 12 to 18 months. 6 months you give cyclophosphamide, change over to maybe azathioprine, give pulses of steroid in the beginning, oral 60 milligram prednisolone you start off, in 2 to 4 weeks, once it's stable, start getting it down and possibly stop it off in 6 months. In a disease possibly like Wegener's or Schurz-Strauss, where the recurrence rates are higher, like Wegener's can have almost 50 to 80% relapse, you may have to give the whole duration for 2 years or 3 years. Sometimes if it is a recurrent disease which is coming, you may have to keep it even up to 3 to 5 years. So, but the principle of therapy remains the same. Now, lot of side effects which occur, but I think this has been beautifully covered by my predecessor, so I shall not bore you with this. I have already mentioned that people therefore tried pulse cyclo to decrease the side effect, but they found the same problem. Remission rates are equally good, but if you notice, relapses are much higher. Maintenance, lot of trials, azathioprine is gold standard, methotrexate especially in Wegener's has been found to be useful. Mycophenolate mofetil is also quite good. Then interestingly in Wegener's, even Septran has been shown to decrease the relapse, though one doesn't give it routinely. Lot of new drugs have been tried, including etanercept was not found to be very useful. In a specific condition, just the last 2-3 slides, of polyarteritis nodosa with hepatitis B, you have to give antiviral drugs also. You may give steroid initially, thereafter one may have to continue, you have to give lamivudine. Now before I conclude, I just took deliberately showed the Indian studies which have been done in vasculitis. I might have still missed out some. It's quite a lot. Why I deliberately showed this study was to show unconnected point. Many a times I hear people who come on the stage, they don't do enough homework on Indian studies and come and make a stupid statement that not much work has been done in India. Trust me, if anyone ever you hear such a person standing, it means he himself has not contributed to Indian literature. Number 2, he or she has not bothered to search the internet properly. Indians are doing wonderful work, I must assure all of you. There are more than 75 journals which are coming out of this country, and if you search properly, you should be able to get lots and lots of data. This is slightly unconnected, but I deliberately showed this slide to show that if in a remote disease like vasculitis, so much work can be done. So never get taken in by any person who ever stands on a stage and has the audacity to make this kind of a comment. A little strong about it, so forgive my language. To summarize, suspect vasculitis in any unexplained systemic illness, which has 3 things, always remember: palpable purpura, mononeuritis, renopulmonary syndrome, put your bet on it. A chronic non-healing ulcer, things like a digital gangrene, etc., reasonably good. But whenever 2-3 systems get connected in some way and you are not able to figure it out, start reviewing literature for vasculitis. There are at least 5 ways of classification. Maybe if I had read more, I could have told you the 6th way also. So, but don't get carried away by classification. This is just different people trying to look at it different way. Understand the principle that at the end of the day, it is organ involvement which is most important. Before you decide to treat, be sure you have ruled out the mimics of vasculitis. ANCA is an important advance and definitely helps the diagnosis, but at the end of the day histology remains the gold standard. The prognosis has improved dramatically. At 80% people used to die of PAN before treatment. Today at the end of 10 years 80% are alive. In vaginous granulomatosis, all these had almost 80 to 90% 1-year mortality. Today they have 70 to 90% 10-year survival, and some studies show even better survival at 12 years. So there is a need to treat these people aggressively, and these at the end of the day, even with so many new drugs, it's the cyclophosphamide, steroids and azathioprine which remain the backbone of therapy. Thank you very much for a patient hearing.
Any questions from the audience?
So,
when the patient is on steroids, sir, is there any need for NSAID also for pain?
Sir, actually, thank you, sir. Many a times steroid itself are excellent painkillers, and both in rheumatoid and in vasculitis, sometimes it's actually, personally I would prefer a low dose steroid which takes care of pain rather than NSAIDs, because in the long term NSAIDs, you see, with steroids when the inflammation comes down the pain disappears, and if the inflammation is down then possibly simple paracetamol would be good enough as a analgesic. For inflammation I personally prefer steroid, and my personal use of NSAIDs is lower than what it is of steroids, sir.
Sir, I have one or two questions.
Sir.
When it is generalized vasculitis, can there be involvement of the coronary vessels and cerebrovascular vessels also? Can it lead to any symptoms and any clinical manifestations there?
So actually cerebral vasculitis I deliberately did not touch because it's a little
Coronary,
sir, coronary, there is the most important vasculitis which affects the coronary was what is the Kawasaki disease, which classically was described by Dr. Kawasaki in Japan, where you have a mucocutaneous lymph node syndrome where a person comes with fever, lymphadenopathy, cherry red tongue, etc. And after the disease subsides, a few weeks or a month later, a person develops a myocardial infarction or this thing. Now besides that, the only other vasculitis, since coronaries are medium vessel, the only other important one which does affect is your polyarteritis nodosa. So if you ever have a young, say 18, 20, 25-year-old person who does not have any coronary risk factor and does develop an MI kind of a thing, he would undergo an angiography, and today more than any time else the angiography will pick up aneurysms and you would be able to pick up this thing. And as far as the cerebral vasculitis is concerned, did you ask about CNS also, sir? CNS vasculitis classically is a middle and the small vessel vasculitis, and it can come with a plethora of symptoms, especially including it can come in the form of a meningitis, or it can come in the form of small infarct, etc. And then you would have to rule out everything else and then suspect that the person might have a CNS vasculitis, sir.
Sir, I have seen two patients of vasculitis. I have referred them to Dr. Chandrasekhar and team to manage it. One was postman having gangrene-like changes in the tip of the fingers. Another is a lady with a non-healing ulcer. And regarding the biopsy is concerned, where exactly you take the biopsy, other than can you take the biopsy in the ulcer or in the fingertip, and say for example, and then if it is a purpura, palpable purpura, can you take a biopsy at the purpuric spot?
Absolutely, sir. Purpura is purpura is the best place to take. Right, the purpura itself we take a biopsy. For the ulcer, one should always go to the edge of the ulcer, and importantly at a place which is not deeply necrosed. So once you have cleaned the ulcer and find where activity looks to be there, that would be the place which would pick up. And more importantly, you would also pick up another disease called pyoderma gangrenosum, which will only pick up by, which is non-vasculitic, but that will also only pick up by a biopsy.
Then this purpura, is it something that transient that comes and goes, or does it stay for a long time? This
Sir, majority of the hypersensitivity vasculitis would actually, since hypersensitivity is hypersensitive to something, let us say if it was because of a drug or it was because of viral infection, it is likely to be monophasic, so it will come and it will go. But let us say if it is because of an underlying malignancy which is hidden, so it will come, go, or it may will remain for a longer time. So the fact that it is remaining for a longer time or it is coming again and again should make you suspect that there may be something more underlying, sir. Maybe it is a malignancy or some underlying connective tissue disorder.
Excuse me, sir.
So-
We have an 11-year-old boy diagnosed as a case of cutaneous pan. He was doing well for last 2 years. This time he has presented with fever, generalized body pain, neck muscle weakness. CPK is 2500 and LDH is 700. So how common is such severe myositis in patients with cutaneous pan?
Sir, myositis in cutaneous pan, it's actually not at all common, because if you told me that this patient has got, it has been shown in some cases that some percentage of cases of cutaneous polyarteritis nodosa may progress to the classic pan. But what occurs, I don't often remember, but I think it's less than about 10% or so. Otherwise, they seem to behave like two distinct entities.
So is classic pan associated with significant myositis?
It can occur, yes.
It can occur.
Definitely.
Because we are not able to make he is on high dose pulse methylprednisolone, but still he is not responding. But he was a case of cutaneous pan doing well. So severe myositis, is he progressing into another connective tissue disorder or evolving into not so? Extra-articular features of cutaneous pan are, is it very common?
No, it's actually quite rare, and only very small percent. I had recently reviewed this about 6 to 8 months ago when we had another patient where we did suspect that, but we found out that only very small percentage of cutaneous pan go on to classic pan later. So, I mean, I would like to review the entire thing to see whether the diagnosis itself was correct in the first place, sir.
Thank you, sir.
I think your enzymes are too high. It looks like a primary muscle disease with
Yeah, the problem was
vasculitis.
the problem was the boy had presented with digital gangrene and skin lesions. Biopsy was not taken to confirm a diagnosis.
PM, because in juvenile dermatomyositis, vasculitis is a common feature. Yeah.
Sir, would it be right to call a vasculitic manifestation in a primary case of neoplasm as sequelae of paraneoplastic tendency, or maybe in an infection per se, say like one of these hepatitis, a vasculitis developed in such a scenario as a para-infectious development? Because
Paraneoplastic, yes, but it is more than a paraneoplastic. It is usually these are all occurring because of your antigen antibody immune complex deposition against in the malignancy, some protein which it identifies and gets deposited in the skin. But I don't know whether it's para-infectious. It is just a simple immune complex deposition. I don't think that word para-infectious is used. But viral infections are notorious for causing this kind of this thing.
what I meant was a sequelae of so many chemical underlying reactions that happen.
I didn't understand the question.
No, as a sequelae of so many complex processes that happen under the cover of an infection.
See, what occurs is that typically viral infections, after a period of time, you can land up having the type 3 hypersensitivity reaction, where you land up, very commonly we land up seeing arthralgias. Sometimes you can have the skin rashes, sometimes you can have even a glomerulonephritis which comes and goes. So all this is in the same group of diseases. So it's not para-infectious, it is definitely post-infectious.
As we are running out of time, can we please continue the discussion during lunch hour? Thank you, Group Captain Dr. Shankar, for a very organized and interesting